So welcome to this second day of the BPH Summer School. I hope you enjoyed yesterday's session and are ready for the interesting tasks of today, which will be about acquisition, processing, and quantification. So it's my great pleasure to introduce you to our first speaker today, Bart Bijnens. Bart is an ICREA research professor in Barcelona. He was first at the University Pompeu Fabra, and currently he's at IDIBAPS, leading the Translational Computing in Cardiology group. He's a recognized international expert in pathophysiological concepts, image-based assessment of cardiovascular diseases. He works at the interface of engineering and clinical medicine, and he's called over the world to give lectures and requested for advice in projects mixing engineering and medicine. So it's a great opportunity to have him today. I could go on talking about his scientific trajectory, but without further delay, I pass the word to him. So, the floor is yours.
Thank you very much. Let me try to share my screen. Okay, that should be fine now, no?
Yes.
Okay, good. Thank you, Jerome, for the invitation in the summer school. It's a pleasure to be here again after all years that we started it. And it's an extreme pleasure to see so many people. So I think this is really filling a need in the education and in the spread of the word of science, and specifically modeling, and nowadays, of course, data science, which is very closely related to it. So I think that's why I've been asked to talk a little bit about some of our projects where we try to use data mining together with physiological modeling in some cases for interpretable patient stratification. I think this is the most important, because in the end, what medical doctors do is patient stratification, somehow like trying to do decision-making in clinical medicine. And that has to be, I think, intrinsically interpretable, and we'll come back to that. And I think the current tools that we have available are sometimes really of the benefit of their use. And it's up to us to find ways in order to do it. What I think is very, very important, and especially as engineers, when you start working in this field, is that you really have to try to understand medicine, because the only way that we can come up with kind of methods that are really useful in clinical practice is trying to also understand how they do it, why they do something like this, and where we can help in order to improve it at some point. And so what you will see is that this is like a general scheme of general clinical decision-making, where you see that you have a certain amount of data available. And as you can see, this is a whole bunch of data. So this is not just imaging data as some people are working with, but it's really everything that is related to it. And sometimes also resources and customs and choice are very, very important. And I'll come back to that also in a specific project. Then we have data, and especially when we look at imaging data, we can have, at the one hand, we have measurements from this, but we can also still have visual inspection, which is actually very, very important. And I'll also come back to that, why that's really important to have. But besides the data that we have, there's obviously also the boundary condition and the pathophysiological knowledge, which is actually being used at the same time as input for the decision-making process. And when you look in current clinical practice, there's actually two ways of making decisions in some ways. And medical doctors are actually merging these. And one is based on clinical experience, and that can be experience from kind of seeing patients, but obviously that's also like experience from learning at the university, for example, which is using an implicit kind of pattern recognition from the medical doctor in order to try to come to a decision. On the other hand, and that's what's kind of evidence-based medicine is all about, that we have clinical trials, cohorts, observational studies, so really evidence from which explicit clinical guidelines are fused, and then this is being used for decision-making. Now, of course, this is in some ways interpretable reasoning when we look at the guidelines, because it specifically said, look, there is this threshold, and you can find in this paper why we use this threshold. While, of course, the clinician, kind of the implicit one, is more black box reasoning. And at the same time, we have explicit pattern recognition that is being used on the way also. So you see already that we have different types of reasoning, of learning, of decision making, which in clinical practice are just very kind of smoothly fused in some way. So that means that if we want to help in this, we really have to know what we are talking about. And what is also very, very interesting is to start to see where problems are in medicine. Where are errors being made, for example, in diagnostics? Well, one of the things is the under-interpretation of finding, which is really important, which means that a clinician sees something and they say, it's this disease because I see this, without further looking to all the rest. So that could be comorbidities, or that could be something which is different, or something which is rare, or something like that. So unless you really go through the data thoroughly, you might underinterpret it. Technical factors are also still a problem. So wherever we can improve in technical factors, that could be important. And very similarly to underinterpretation is incomplete examination. So that means that you start to acquire the data and you say like, I have already enough data in order to make my decision because it's so clear that it's this. But if you would have looked further with some more data, or kind of trying to look deeper into it, you would have kind of seen other things. So these are things that in reality are important. So one of the questions is, why is this also happening? And again, it's very interesting to see how people are making decisions in some ways and trying to understand where this comes from. And there's a very interesting study that is saying like, when we are thinking about a problem, when we're making a decision, there's actually ways that we can do this. We can do one, which is very intuitive, where we do really pattern recognition. So our brain is extremely good at pattern recognition. This is fast, but the thing is, this is prone to errors. And here is a very nice example of a study that they did with radiologists, where they took CT images of the chest and they embedded digitally a gorilla into there, and then they gave it to the radiologists in order to kind of try to make a protocols or diagnostics on this CT thorax images. And what you see is that 80% of the radiologists did not see that there was a gorilla embedded there. So this is just because they weren't trained in order to do it. They were using their fast recognition. They were looking for lung nodules or other kind of diseases that they knew, and whatever they didn't know, they really missed. Now, on the other hand, we have what we can call kind of type 2 or slow reasoning, which really starts to think about it. It's analytic, deliberate, and really uses thinking in order to come to a conclusion. And here is another study, again, with images that is kind of illustrating this. So they took these chest x-rays, and as you can see here, they removed the clavicular. So this bone is missing at this side. Again, if they gave this to the radiologist saying like, look for lung nodules, about 60% didn't see that this clavicula was missing. But if they asked and said like, look, these are chest x-rays from a study of patients where we used a new drug, can you see if anything is going on? Then almost everybody would find this. So you see how they switch depending on the question from either this fast reasoning to the slow and deductive reasoning. And I think this is really important when we, for example, start to use deep learning and data science, because I'm not going to go in all the details, but you know, there's many kind of machine learning algorithms from which deep learning is the most popular at some point now. But you can already imagine that deep learning, what it does is this very fast pattern recognition. And actually using this, we have been able to reproduce a lot of kind of human tasks, which are actually high level. When we go to images, for example, this is probably the best approach in order to do image recognition. And we see that this is very popular. But again, this is using this, what I said, this pattern recognition. And I think this is really important to understand, because here you see, and to me, quite interesting study where they actually trained a bunch of pigeons in order to make a diagnosis on kind of morphology, so microscopy images. And they trained the pigeons to discriminate benign versus malignant, so tumors versus kind of normal tissue. And they could actually show that a flock of pigeons is actually better than a trained deep learning network, which is actually logical when you start thinking about it, because pigeons are, of course, also using a brain, which is a neural network. And of course, still the pigeon is better than currently our best algorithms. And so you can imagine that this is going to be better. But again, this really shows that this type of reasoning, this type of analysis that we do is this pattern recognition. So wherever there's pattern recognition without reasoning that needs to be done, then this type of algorithms is actually extremely powerful. But be careful, because of course, this is very dependent on the learning. And here is an interesting, quite controversial and in some way crappy study, but it just illustrates that if you train a neural network in order to recognize COVID X-rays or chest rays from COVID patients, what you see that it does actually quite well on actual chest X-rays, but it actually recognizes this type of images also exactly as being COVID, because again, it's something like a black kind of whitish foreground on a lighter background. So it's really important that you keep checks and balances, especially for outliers. And in medicine, very often outliers are really important because these are the ones that you shouldn't miss. In a lot of cases, you come to patients which do have kind of some complaints and mostly have the same disease. But if they are, for example, an outlier and you miss this one, you are prone to miss the most kind of severe patients. So really looking at outlier management is really important. And then is it worthwhile to use this type of pattern recognition in medicine? Well, I mean, of course, it's useful in the sense that here, for example, you see actually quite a difficult task in image classification. And you see that deep learning is actually not doing too badly. The only thing is that once in a while, you see that it takes a muffin for a chihuahua or a chihuahua for a muffin. And the thing is, with images, this is not too bad. I mean, you don't care too much about it. But if this is a patient and you're that patient which is wrongly classified, and there are no kind of checks and balances in order to make sure that this is not happening, then this is a whole other question. So we really have to see why we use this kind of thing. And another thing that is also very often happening in data science, and especially when engineers are analyzing medical data, is that there's always hidden associations, or associations which might be hidden and which might be true or which might be kind of not very useful. And here are two very interesting studies showing this. Let me show this first is with COVID, for example. So here, based on Twitter, you can actually predict the number of COVID cases that are in a certain country, which is in a way logical, because people are tweeting. It's like, okay, my neighbor has COVID, or I have COVID, or I've been tested kind of positive. So obviously you can get the number of cases, or at least an estimate based on it. And here's another interesting study where you actually can predict cardiovascular diseases also based on Twitter. And you can really see that where the computer predicts that cardiovascular deaths would occur and where there are actual cardiovascular deaths, you see that this is a very, very overlapping. And obviously the reason for this is that people are tweeting, like, say, for example, okay, I have an appointment with my cardiologist and I'm going to McDonald's today and I've smoked a package of cigarettes. So again, these are associations and not really, of course, diagnosis. So we really have to take care that we do recognize this. Now, one other thing which is also really, really important is to see what's the data that we learned from. And in medicine, the problem is that there's really very different types of data. And mostly the data that we have available in order to work with is data from clinical trials or from research. And so we have really, really standardized inclusion criteria, which is actually selected. So we have a pre-selected group of patients. We do very specific data acquisition with a very strict protocol. We choose a treatment, sometimes like a randomized treatment, which is always the same dose. And after a fixed period, we look at the outcome. However, when you go to clinical routine, everything, literally everything is different. First, you come into a medical doctor with symptoms, which are always different from the different patients. Then you go, either you have an hospitalization, a consult, depending on the specialist. This will depend on local practice, for example. Then whatever is available locally, or what are the guidelines that they're following, they acquire the data, which can be different. From this, they do some decision making, which is very experience dependent on the clinician. And then treatment is being also looked at. And then the follow-up can be random, or the patient is sent home and you wait until they come the next time. So the temporal dimension is also very, very different. So everything is non-standardized. The timing, the data that we have, the treatment, the initial kind of selection of the patients. So that means that we really have to take care of what we're doing if we want to tackle that second problem. So it might be that you want to tackle the first problem, which is fine, but you have to be very aware that in medicine, you have these two very different things. And then also even the data that we get. I mean, what you normally do as a data scientist, you say, okay, this is my data. Maybe you get an error with this, but mostly you say, this is my data, these are my labels, and I rely on this, and I'm going to use this, and I'm going to train a network. But sorry, medicine is not like this. And here is just an example. And this is the measurement of ejection fraction in cardiology. And this is actually from a randomized controlled clinical trial where an inclusion criteria was that the ejection fraction has to be below 30%. That's a strict inclusion criteria. And so here you see in blue the measurements that were done by the centers of the multi-center trial that did the inclusion and did the measurement. And these are measurements according to specific guidelines that they need to do. And based on this, there is an inclusion. And what you see, first of all, is that this is being kind of binarized. So this is binned in some ways. So that means that there's no continuous measurement, but people are kind of rounding the ejection fraction, which means that this is not a proper measurement in some ways. And so, of course, when the data was coming to the core lab, what they did is they remeasured the data. And now you see a nicely expected Gaussian distribution in some ways. And you see that actually there's a whole bunch of patients above 30%. So you can say like, okay, is this an error or is this a bias where people said like, okay, if it's above 30%, I cannot include this patient and maybe I get paid for including this patient. So you really have to make sure where the data comes from. And just a few things, just to put your mind to it. It's like, my experience is that in clinical practice, any data that you get, whether it's from imaging, whether it's from lab measurements, whether it's from genetics or anywhere, the best you can do is plus minus 5% of error. So the accuracy is never better than a range of about 10% of your value. A clinical diagnosis, and that's why they sometimes also call it differential clinical diagnosis, to me is much more a suggestion than a fact. So if you use this as a label, you have to clearly keep that in mind, that maybe it could be something different or not as clear. Now, even when you work with these kind of randomized controlled trials where you have hard endpoints saying like, look, we look at patients dying, for example, you have to keep in mind also that these run over a certain period and that you have no idea whether a certain patient would die tomorrow after the deadline or kind of 10 or 20 years later. So even that label is not very accurate in some ways because it does present this hard kind of label that you would really think about. Also, the disease progress itself or the process is different. In everybody, it has different extents. It can be kind of different localizations or things like that. And also the disease progression, of course, is smooth. And the entry of your patient can be anywhere on this disease process. So that means that the data that you're using, if you treat this as hard data, almost everything you're assuming can be wrong. So it might be that you have a brilliant classifier that was classified or that was trained on a certain data set. And when you start using it in clinical reality, it doesn't work at all. This is also very related to models, for example. If you make physiological models based on data, and you have, for example, one measurement, and you say, okay, this is my golden truth, and then you do a couple of other patients, it's like, this is never going to represent clinical medicine. So all of these factors of continuity, of smoothness, of different disease processes, you have to put in there. So you really have to look at these kind of parameter spaces and how this links to clinical practice. So then if we go a little bit deeper into the decision-making process, and then, of course, where we can help with our data science, so you can actually make it in this kind of generalized kind of workflow. So a patient comes into a hospital or with a medical doctor, and the first thing that happens is obviously data acquisition. That can be imaging, that can be labs, that can be talking to the patient, which is also, of course, data acquisition and so on. And so you have a whole bunch of kind of raw data that comes in. And from this, you extract features. So you do some measurements, some features. So you kind of reduce the dimensionality of this data by taking a couple of parameters that you think are relevant for your decision-making process. Based on these parameters, on the conglomerate of these parameters, and that's also like, for example, the age, the sex, the kind of social status of the patient and things like that, you put all this information together, and then the medical doctor will make kind of in their mind a kind of a state of a patient, a representative, a mental representative of this patient, which they then try to interpret. And the interpretation is by comparing it to populations. Comparing it to knowledge of populations that the medical doctor saw before or was trained for, comparing it to guidelines, comparing it to clinical trials. So this is done by comparison in some way. Keeping in mind that the medical doctor very implicitly will take uncertainty from measurements into account, and also reliability of from where the data comes from. So it could be that the patient comes, for example, with an ultrasound examination that was done in the field by a small machine, and something was done from it. They can say, no, this is not really reliable, let's redo this. And so this is information that they use. This uncertainty and reliability are very implicit. So that means that if we want to use this, we have to either learn this or use information from this, for example, through models. Based on this state and based on this interpretation or comparison, a clinician would make a decision. A decision could be, okay, we're going to do therapy. A decision could be, we don't have enough information to make a decision and we go back. Or the decision could be, okay, here, you can go home and come back whenever you feel this kind of thing. So what we do, I think, has to fit in some ways in this kind of things, in this kind of scheme. And then you see that there's like different tasks in the scheme where we can help. First of all, data acquisition can be better because we said, for example, technical problems are a source of errors. Feature extraction, so doing the measurements, is kind of also something which is quite useful because very often this is a tedious and time-consuming job. And both of these are relatively low risk because it's very clear if something goes wrong. And also, these are only small facts very often in the whole decision-making process. This is only one part of the information that you're going to use. It's never be that everything relies on this. Now it becomes different at the moment that we have to do the interpretation. So where we do the comparison with our population, as I said before, here it becomes more difficult in the sense that the risk is higher. And here is also where our problems come in, where we have to compare to populations, where the reliability and so on comes in. So this is another kind of task that needs to be done. And then, of course, making the decision or helping making the decision for therapy or something else, whatever, this is the most difficult and has the highest risk, because if you make an error, this can be really serious. And so we can see that in all of these things, we can have ways in doing it. So the challenge of acquisition and feature extraction is that it's very often difficult to learn and needs experience, and it's cumbersome and time consuming. So you will see that this is really the task for example, deep learning. If you have a lot of data, and you often have, this is a way that you can do. And also the errors are not that important and the risk is relatively low. And the interpretability comes from the data itself. So if you do a segmentation or feature extraction, you can almost immediately interpret whether this is wrong, yes or no. For the rest, there's nothing of more reasoning behind it that's important. But decision support is something different, as we said before. It's high dimensional, heterogeneous. You need dynamic data when you look over time. It's often very non-standardized. And here it's really key that this is interpretable for the medical doctor, and it fits also in their way of working. Medicine is there for thousands of years, has evolved, and it's likely that it's a reasonable, optimal way of doing it. The whole process itself the decisions itself and the knowledge might not be optimal, but the process, I think, is reasonably optimal. So if we can try to keep that process, then I think that's really important. And interpretability, of course, here is key. I'm not going to go in very much detail, but currently in data acquisition, for example, in echocardiography, in feature extraction, you will see that machine learning, deep learning is already there. There's several machines, several vendors that are doing. So we go a little bit further towards the interpretation. And so there's a couple of papers now that also say like, okay, give me a whole bunch of images, give me the diagnostic label, and I'll train a super network that is very, very accurate. This is exactly what they did in this paper, for example. So here they used echocardiography patients of normal patients, and then they tried to predict which of the patients had left ventricular hypertrophy, so had some type of hypertrophic kind of cardiac disease. And they were extremely good at finding out the ones which had hypertrophy, so had kind of thicker walls. The problem is when you start to look at their normals, and in their paper, they put these as examples of normals. And when you look in this middle heart, this is absolutely not normal at all. This is actually what we call a dilated cardiomyopathy. You see that these ventricles are much more rounded, much kind of larger, with much thinner walls. The problem was they didn't have that label. They weren't trained for this. So here you see already that it's very tricky in order to do these things. So you have to take very much care in what you're training and what your system is really doing. This also shows to me, and that's especially since quite a lot of you are kind of engineers or kind of physicists or something like that, if you want to tackle these problems, learn to look at images. Before you train any network, you have to already be able to visually see like, yeah, this is not really a normal heart, so I have to be very, very careful. So really looking at data, going with clinicians in their daily practice is something that every data scientist, I think, has to do. Now, the other thing is also, and I partially mentioned that before, every clinical decision process is like integrating data. So you have a huge amount of also very heterogeneous data. So you have binary data like sex, for example. You have continuous data like age or lab results. You have imaging data, which can be quite complex. You might have signals there. And then, of course, you have all the knowledge and the previous history. So we have to find ways to do data integration there also. And here is a typical example of how actually an echocardiography exam should be interpreted. It's like you look at the images. And when you look at the images, you see, for example, that there's a little bit of this bulge here. You say like, this is something that I know about. Or you might have that it's like thicker everywhere. So kind of getting features from the images is important. There are measurements that we do on these images. And then there's here, for example, these are kind of myocardial deformation traces or strain traces where values might be useful, but where also patterns might be useful. Because here you see a typical pattern of, for example, reduced deformation with post-systolic deformation. I'm not going to go into details here now because of lack of time, but I can tell you that this is a very specific kind of pattern that we should recognize in order to make a decision. And besides that, and especially for what we call diastolic function, so how the heart fills, what we need is we need Doppler flows over the valves, where we can look at mitral valves. We can look at kind of other valves, kind of or regurgitations in valves. We can look at motion of the wall. And it's by interpreting all of this that we make our decision. Now, according to the guidelines, what we do is we extract measurements from this. From each of these things, we extract a certain measurement. And then based on kind of decision trees, we're going to look at this and we're going to make our decision. You can already see that this data and the potential patterns are much, much more complex than can be represented by this data. So can we find ways in order to do this better? And an interesting thing there also is with regard to, for example, this kind of knowledge on patterns. Here's an example of when you look at the textbooks of how diastolic function in the heart is changing, you see that depending on this degree, depending on the local pressures in the heart between the ventricles and the atria, for example, you see actually that flow patterns, that motion patterns, that sometimes two-dimensional flow patterns, that they are showing some specific changes. But also with changes here, for example, what you see is what's called pseudonormalization. So it becomes abnormal and then it becomes a little bit more normal again with more disease, and then it becomes very abnormal. So you see that these are complex things in some ways. And the way that clinicians currently are kind of summarizing this or putting this into a workable kind of diagnostic system is by creating these decision trees. But if you start looking at this, you see that this becomes a mess in some ways. And you see also that this becomes more and more complex, the more people learn. And at some point it doesn't work anymore, because here it's like, okay, do we have 3 criteria? If only 2 criteria are there, do we do this? Do we do that? And you know that this is already kind of just looking at a certain amount of patients. And this is what practice also shows, is that if we start using this in order to summarize this, this is not being used anymore by a lot of clinicians. So we have to find ways in order to kind of quantify these patterns in an interpretable way also. There are some kind of techniques like hierarchical clustering, for example, that can get us this way. The problem is that this again only works on the measurements, not really on the whole traces. And there's other ways, and I think this is ways forward if we want to kind of investigate or kind of make systems to support the clinicians. And this is something that we have been looking at over the years and are still heavily researching. So what we do is we take all the data, and that can be heterogeneous, that then can be complex imaging data, for example. We find some ways to integrate this. We do this currently by dimensionality reduction based on multiple kernel learning, and we come back to that later on also. And what we do there is we try to phenotype the patients by finding a way to do a transformation where we go to a lower dimensional space, where we actually order patients in some kind of graph way. You can order them. You order them based on similarity of the complex data. So it's in such a way that patients that are located closely to each other have similar data for this whole conglomerate of data, and the further away they are, the more different they are. And what you now can do is, of course, try to these areas, find different kind of, for example, diagnostic labels. And also keep in mind, this doesn't need to be kind of dichotomic. This is not one disease or the other. It could be that these are different diseases depending on where the patients are located. And so we can somehow quantify which is kind of a diagnostic label. We can then associate, of course, if we have that data, we can associate a certain risk to it. Keep in mind that this first part can be totally unsupervised. You just look at the data. You don't need any other information. Obviously, from the moment that you put diagnostic labels or risk on it, you have to do it supervised and get information from some trials, obviously. And then based also on this, what we can try to do is find for certain kind of areas the best therapies that would fit with this type of risk and this type of etiology in some ways. And all of these things we can use some kind of data science and machine learning. So here again, it's summarized. What we do is we take a bunch of patients, we take a bunch of features, we do dimensionality reduction, where based on similarity of features, we can try to do an interpretation, which gives us what we call some phenotypes of phenogroups, where you can do risk assessment and treatment planning associated with. Now, this is what you do in the learning phase. And keep in mind, this is learning, of course, in order to train a model in brackets for being using later on. But also this helps you very, very much in exploring why there's different phenotypes and how they differ. And I'll show you what this means in a minute. Sorry. Next, of course, when you now want to use this in clinical practice, what you do is you take an unknown patient from which you have similar features. You try to project this patient here. And what you now do is by association, you have the phenotype, which is related to the risks and which is related to potential treatment. And very interesting and nicely, what you can also do, this naturally leads to a temporal evolution, because what you can see is if you have data at different time points coming in, what you can see is you can look at temporal evolution. So you can say it's like for my population, what we expect, for example, when children are growing or something like that, what we expect is that the data moves in this direction. If a certain patient then moves in a very different direction, we know that something is wrong, that this is an outlier, that this is a higher risk or something like that. So we can also use this for temporal evolution. Let me show you a couple of examples of this and how you can actually use this in clinical practice. The first study is about dilated cardiomyopathy in children, under 18, so in pediatric cardiology. And dilated cardiomyopathy has a very high morbidity and mortality, in the sense that almost 50% of these patients that are diagnosed with severe dilated cardiomyopathy will either die or need a transplant in order to survive. And so we have data, including echocardiography, and we try to see whether we can know something about, try to understand these patients. It's like, why are some sicker than others, and try to see whether we can use this to predict, of course, the ones that are also at higher risk. So what we do is we take the complex data. So in this case, we use echocardiography data where we use the flows, and we do some segmentation in order to do and the maximum velocity profile over time. That's really important because it's this shape changes over time which tell us something about the pathology. And then we take in the different segments of the myocardial wall, we can look at deformation. And again, these are complex traces over time where we try to integrate these patterns, for example. So here we have the different patterns. We, of course, need to do some normalization, some temporal alignment. And we use this as input for the learning. And what is also important is that we need to add age and body surface area, because these children are, of course, growing. And depending on the age, you have a different heart rate, a different heart size, a different amount of deformation. And body surface area is also related to heart sizes and cardiac function. Based on this data, what we do is we do this dimensionality reduction. We do clustering in there to look at phenotypes. And what we then do for interpretation, for example, is compare this with other clinical measurements that we have. We know which is the therapies that were being done. We know which are other measurements extracted from the echo, which are traditionally used. And we, of course, know the outcome. And so here you see an example of what happens there. And so here you see kind of patients that survive versus patients that die. And you see that in this space, they're very, very different. And you see that there's areas of much, much higher risk compared to others, which means, of course, intrinsically that the data that we use for the learning is very different because of this. And the nice thing with this approach is that we can explore this. We can say it's like, okay, how is my input data changing over the different coordinates, over the different dimensions in this space? And what you nicely see here, and again, I'm not going to go in detail, so you have to believe me that this is the pathophysiological interpretation. What you see is that the more disease, the more at risk, you see that there's a delay in the contraction, and there's a very kind of what we call this much rounded, decreased kind of cardiac function. So this is for the outflow. And we see that here, for example, we start to get a fusion of early and late kind of filling, which means, again, that we have either a very high heart rate or very, very diseased hearts. And similarly, when we look at pulmonary vein flow, this is how the blood goes from the lungs to the left atrium. What we see is that we have this kind of very typical pattern of what we call very dysfunction, where especially also this delay is very important. So we see that based on this learning, using the risk and see how the data changes, we really see pathophysiological processes that we know. So we really know this pathophysiology. We can even model this pathophysiology, and we see that we recognize this. So this gives very much confidence on saying like what is important. And we can actually look also at the differential change between, for example, the systolic function, so the pumping of the heart, and the diastolic function, the kind of filling of the heart, where there's always this controversy. It's like, what is causing the failing of this heart? Is it the ejection or is it the filling? And clinically, that's very, very relevant because the treatments can be very different. So you see that we can recognize for confidence, but we can also learn pathophysiological knowledge by looking at these things and trying to see, okay, why would this be associated with abnormalities? And then the next thing that you can do, of course, is doing some supervised clustering. And what you see now is that actually we identify, for example, 5 clusters here, where there's clusters which are normal. So all the normals cluster together, all the abnormals cluster also together. There's like a change, a very different kind of ratio of risk depending on in which cluster you are. So you can really do risk prediction. And for each of these clusters, we see what is the pathophysiological reason why this is happening. Now, really interestingly, there's this, for example, this one outlier here that you say is like, okay, according to clustering, this one should be a normal, but actually it's a patient that died. And when we started and we looked back to it, actually the data that we used was actually kind of more than 1,200 days before the event took place. So it's clear that here we captured, okay, something is already going wrong, but the patient hadn't moved to the high risk area yet because we didn't use the right data. So here you see that in order to interpret this, what you need to know is you need to know the pathophysiology, you need to know what's going on with the cardiac mechanics, and you need to know what your data is, where your data comes from, and then you can really use this for interpretation. And as I said before, this gives you kind of phenotypes which are very clinically relevant. And one of the things that you also see is that actually the splitting of the normals, for example, is actually in age groups. While we didn't use, so we used age for learning, so that comes in, of course, but with age also you see that all these variables are changing as we predicted already. And similarly, also in the abnormals, we see that the old ones and the young ones can behave very, very differently. So here again, even if you look at an adult population, looking at, for example, 80 years old versus 30 years old, this can be really important and you have to keep that in mind. So to continue further on this, it's like, as I said before, is trying to understand these patterns that are associated with a certain etiology. That is really important. And actually, not only should we do the learning, but we also have to explore this and to understand this better, right? Because that is how we can continue with science. And here's another interesting project that is going on now, where we look at hypertrophic heart disease. So these are patients with kind of very, very thick hearts. And there can be different etiologies because of this. So one of the reasons why you would have a very thick heart can be that you have very high blood pressure, so that you have hypertensive heart disease. So you see here, for example, is one with hypertensive heart disease, or it can be because you have a mutation in your sarcomere, so in your contractile proteins within the heart, which would lead to what we call hypertrophic cardiomyopathy, so which is very typical, a genetic disease. And based on the thickness and the motion of the hearts, we can do a little bit of discrimination, but actually this is very often not enough, especially not in the beginning of the disease. Or for example, if we have athletes which have bigger and thicker hearts, for example, is there an underlying genetic mutation which might be prone to problems? And the problem is, of course, with this genetic mutation, you might have arrhythmias and sudden cardiac death. So it's really a potentially lethal disease. So it's important that you recognize it. And what you see is that actually over the years, we have learned that, for example, looking at strain patterns together with flow patterns, besides looking at the imaging or at the kind of the shape and the thickness, can be quite important. And it's a little bit small here, but one of the things that you can see is here in this one, which is kind of a severe case of genetic cardiomyopathy, you see this kind of abnormal patterns. So now the first thing that we do is, of course, is use this information again to do this dimensionality reduction. I'm not going to go in detail here, but what you see is you see this kind of spread again, where you see that the ones with this hypertrophic cardiomyopathy versus their relatives, in this case, they have a different distribution, where you clearly see that some are kind of at extremes. But what you also see is that there's this middle group where relatives which are currently clinically not diagnosed as being symptomatic, compared to the symptomatic ones, that they have very similar data. So again, this shows you that it might be that these either the ones with the clinical data, they kind of have symptoms, but the ones without symptoms might have the same underlying heart or the same underlying disease process, and maybe they have symptoms tomorrow. So this is one of the things that I told you before. There is this continuum and this overlap, especially when we look at genotype, phenotype. Again, we can recognize some of the pathophysiological processes. And one of the things that we can do now also is, of course, like look at how other populations are looking at this. So when we look at healthy controls, we see that healthy controls are located here, far away from the more diseased ones, but also away from most of the relatives, which we thought that were normal, but are clearly not normal. They might be carriers, but they're not having the overt phenotype, but they still have changes in their cardiac function. And then when we look at kind of comorbidities in brackets or similar disease processes, like example hypertension, we see then again that there's some overlap, but there's also an extension into one direction, but never into the other direction. So this really helps us in trying to understand some of these disease processes, and we can use again clustering in order to do it. And so now we can look at all these individuals and see how their data is changing and try to use this for interpretation. But going one step further, and that's again where I think that as a data scientist, you really have to go deeper into trying to understand what you're looking for, and that collaborating closely with clinicians, I think, is really important. So what we did is in some of these hypertrophic cardiomyopathies, they have so thick walls that they're actually obstructing their own internal part of the heart. So what needs to be done then, and here you see an example of this really, really thick wall, and this actually hampers the flow towards the aorta there. So what a clinician does is they actually would cut out a piece of muscle in order to open again this kind of flow tract, and then try to reduce the symptoms and the risk of the patient. So what we've been doing is we have been collaborating with the surgeons, and we have been collecting these tissues, and then we used kind of synchrotron phase contrast imaging in order to look at the underlying kind of tissue structure. And so what we do there is we go to the synchrotron. In this case, we went to the Swiss synchrotron, to the Tomcat beamline. And what we do there is we can get very high resolution images of these hearts. We can really go into detail to a resolution of about like 0.6 micrometer in pixel size. So we can really look at cellular or collagen matrix level. And so here are 3 patients that we did in this case. And here is a patient, first of all, with hypertension, where we first looked at these patterns that we have recognized with our learning and that we try to interpret. And what we see is there, like, okay, we see here this reduced deformation with a little bit of post-systolic deformation, which is diffusely reduced when we go towards the septum, where actually the tissue was being taken out. And when you look at the tissue here, what you see here is there's a regular distribution of the myocytes, of the cardiac cells. So these are these cardiac cells. But you see that interleaving, you see these white structures. So this is kind of fibrosis. So there's a huge amount of fibrosis. And when we segment this fibrosis, you see that this fibrosis is really regular. So these are like sheets of fibrosis, which are following the matrix. So what you see here is like we have a regular maintained cardiac microstructure with more fibrosis, which of course kind of increases the stiffness and decreases the contractility. And we see, for example, also that we have vessels with a normal morphology. Now, here is another patient, which is kind of positive for a mutation. It doesn't seem to be so thick. We see there's some thickening, but what we see here is that there's very, very abnormal deformation patterns really localized in this basal septum. And we look here at the tissue. What you see now that you have like an enormous amount of kind of fiber disarray, as we say. You see there's no regular structure whatsoever anymore in the distribution of the cardiac cells. When we look at the fibrosis, we see that again, this is a whole mess. So this is like really disarray of fibrosis. There's no normal architecture anymore. And when you look at these vessels, they're very, very abnormal. So here, this kind of underlying structure and the pattern that comes from it is of course because of this very much tissue disarray. And here's the last patient. This is like a really overt kind of abnormal patient. So you say like, okay, this is really a genetic cardiomyopathy, but if we tested it with the current genes that are tested for this disease, actually the patient was negative. But there's no way that there's no genetic abnormality. The only thing is that, of course, we don't know it. At least with the testing that we did, that normally clinically is done, we don't know it. So here again, you have to be very careful again with the genetic labels, because the deformation was very abnormal. And when we look at the tissue, you see like that this is kind of nothing normal at all. Although all the individual myocytes are normal, you see how they are very crisscross organized, again with some vessel abnormalities. But in this case, there's not a lot of fibrosis, but the fibrosis that is there, or at least the fibrous matrix, because I wouldn't call this fibrosis, again, it's very disarrayed. So really combining our knowledge of patterns with our knowledge of the underlying pathophysiology and combining data helps us very, very much in understanding where this comes from and how we have to interpret this kind of data. Now, what is also always a question with this kind of studies is like, can we use data from one study to the other, or do we validate it? Because that is also another problem. And validation can be done, of course, with exactly the same cohorts which are independently taken, but very often we don't have these. And here's an example of how this type of methodology can help in data integration, where we can have data from a general population. So this is from the what we call the ERIC cohort. So this is a cohort that they have been following. We can compare that with a clinical trial of heart failure with reduced ejection fraction and a clinical trial of heart failure with preserved ejection fraction, which are clinically very different entities. And so we can learn from one, we learn from the cohort. You see the cohort is in green, and we can then project the other studies onto it. And you see here, when we look at the green cohort, you see it's mainly located here, but you see that there's quite some green patients also here. And then we see at the blue ones, which are the ones with preserved ejection fraction, and the red ones with the reduced ejection fraction. So you see that they are really kind of with a center of mass very, very different. There is some overlap, but there's clearly some very differences. When we look at outcome, you see that it's really the outcome which is much higher in this lower tail. But not only that, we know in the red kind of ones, which are the so these are the ones that died, but also when you remember the trial with the reduced ejection fraction, most of these were located here, and we know that they have an extreme risk. But what you see here also is that the ones in the normal population, which are located there, also have a high risk. So you really can kind of put information from one trial to the other and try to integrate these things. And again, when you interpret it, it also makes a lot of sense, because you see here, for example, that deformation is reducing with reducing ejection fraction, obviously, because that's how the trials were being looked at. You see how this changes. So again, what this type of methodology kind of very logically lets you integrate data and then do either interpretation on one or the other, or the integrate one in order to look at prediction. Again, you can do clustering, and you see, for example, then that from the general population, the ones which are in the cluster, which is similar to heart failure, these are the ones that die much, much more also. So what I said before, you can translate knowledge from one to the other. Now, all this is well, but as I said before, what you need to do, or what very often happens in clinical practice, is that we are with a temporal follow-up, that with a patient, that we either need to look at the patient over time, kind of during the lifespan or during treatment or whatever, or over a very short period when we do, for example, an exercise test or provocation test, for example, where data is changing on a very kind of short time scale. Or here's an example of labor monitoring. So where a woman comes into the hospital to give birth, which is a process of several hours, of course, where data can be changing. And what we need to do is predict if everything goes well. And especially when we look at kind of problems with pregnancies or problems with deliveries, especially in lower income countries, these are potentially very important. And so again, this problem of labor and labor monitoring comes down to the same scheme as we always have. So a woman comes into the hospital or the place for delivery, has certain kind of baseline data, and then there's data that we monitor over time. Based on this data and the change in data, we kind of make a status of this patient, we interpret it, and then we say, okay, this is normal progress or this is abnormal progress, and we need to do an intervention. And for example, in the end, do a cesarean section because the risk of the baby and the mother is kind of too much. Or we do, of course, watchful waiting, and you really iterate in this until birth is given. Now, the World Health Organization has years ago developed a kind of decision support system, which is called a partograph. And this is actually a paper where over time you add measurements of the fetal of the mother. And some of the things, for example, is looking at cervical dilatation. So how the mother is opening to let the baby pass. And you see that there's a certain expected trajectory. And if you're too slow, there's first an alert line, as they say, or an action line where you need to do something because the risk becomes too high. Now, the problem with this is that actually it kind of, well, one of the things, let me come back to that first. One of the things with labor monitoring, and it's actually, you can translate it to many of the other kind of clinical situation, is that practice can be very, very heterogeneous. So first of all, when does a woman come to the hospital? Some come very, very early, some come very late in the process. So of course, this entry is very, very different if we want to make a system. The period in which we sample, it can be every hour. Sometimes it's kind of hours later, sometimes half an hour. So this is totally non-standardizedly sampled. But the decision for intervention is also absolutely non-standardized. And here you see, for example, the incidence of cesarean section in different countries and split out over the kind of wealth of the people. And what you see there is that in some countries, and for example, in Brazil, it's supposed to be more than 75%. What you see is that the rich people, they very, very often get a cesarean section. Because very often it is like, okay, I have to plan my baby's birth because in the morning I have to go to the hairdresser in order to have nice Instagram pictures, for example. Well, of course, that the poorest ones, they're not able to go to the hospital, so they will never ever be able to have a cesarean section. And what we know is physiologically, clinically, about 10 to 15% of deliveries probably have a really medical need. And so you see that this varies very, very much. So if you now use as label, or you want to predict cesarean section based on data which comes from these different places, you know that there's this enormous bias. And the question is, how do you filter out the information which is relevant from the information which is more practice or choice? And that is things that we have to do. And here's an example of a study that we did, and this is on data from the World Health Organization, which is called to study BOLD for better outcome in labor difficulties, where we had about 10,000 kind of deliveries where we had data at admission, about 100 features, and then features which are taken kind of over time during the delivery. And one of the things you also see now already is that here, also there were 2 different countries, and you see that the intervention rates, so when a decision was made for an intervention, is very different depending on the country. The time of these decisions and the time of the delivery is also very heterogeneous. So you see a lot are located around kind of early times, but what you see there is you really have these outliers of very longer ones. So you have to be able to take that into account. Many patients have different interventions. And these interventions are, of course, if you try to predict something on the data from the beginning, and in the meantime, an intervention has been done, of course, the trajectory or what you expect from this patient is going to change. And then here is the data from what they used in the past, where they said it's like, okay, if it goes beyond these lines, especially here in this part, you will have much more likelihood of problems. You see that the gray ones here are good ones without any problems, which are very delayed, while the red ones are some which are very early and do have problems. So the data that was being used there seems to be not, or the information was not very useful. Again, what we can do is we can use this data, do dimensionality reduction, as we said before. What we do now is try to look at trajectories over time. You want to see in this space, how is this data changing? And what you can learn is you can say, it's like, okay, I learn from the normal data that we had, which are the trajectories which lead to normal birth without any intervention, which are the ones that lead to intervention, and also, depending on neighborhoods, which are interventions that have been done on a certain study. And so we can use this for a new person, like we have a new mother coming in, we know the baseline data, we can follow the trajectories, and we can really over time try to see what's happening. I'm not going to go in detail here because of lack of time, but we can see that this is actually outperforming the pathograph. And although it remains a very, very hard problem, especially to detect death, you see that there's also very interesting things that you can learn from this. And you see, for example, distributions where you see, for example, cervical dilation, you see how that moves over time. And you can really see these things. But one of the things is that there's, of course, a split in countries that we said before. So there's not only a split in countries in practice, but there's even a split in countries in data, which could be based on the baseline data. So it could be based on the demographics in some ways of the population. But very often is also like here, for example, you see on how they kind of describe or define cervical consistency, which is like the hardness in some ways of the cervix that they kind of feel. You see that different countries interpret this differently, actually. So again, the data that you use is only valid in a certain setting. That's always important to keep in mind. And actually, based on this, you can make a decision support system and then use this. We don't have kind of time to go in detail, but anybody that's interested can contact us. So as a last example, I quickly go over an example of how we can use this to monitor fetal well-being. As I said before, we can use this for looking at the mother during labor, but we can actually use this also in order to look at the fetus, for example, where we look at the fetal circulation. And what we know is that if the biggest problem or the most prevalent problem with fetuses that can lead to problems or death of the fetus in kind of our world is what is called fetal growth restriction. And what happens there is that actually the placenta becomes too small and is not providing sufficient oxygen and nutrients to the baby, so that especially at the later times of the pregnancy, the baby really comes into trouble, and that can lead to death. This is what we have to detect. And the way they detect that in clinical practice is by looking at the dynamics of the blood, where in a normal heart, you see that with the fetus, what you have is that the systemic and the pulmonary circulation, of course, are linked to what we call the ductus arteriosus, because the lungs are, of course, not working until the baby is born. Now, looking at the flow here, normal flow goes from what we call the right ventricle over the ductus arteriosus towards the placenta in order to get oxygenated. If the placental resistance becomes so high and we get into trouble, then what's happening is what we call brain sparing, but of course it's hemodynamically because of pressure differences. What we see is that actually we get reversal of flows. And they actually detect that by reversal flows in the aorta here, and by also changing in the profiles of the other flows. For example, the flow towards the placenta. Now, what you can see is also this is a gradual process. So this is not a black and white. So this is something where the hemodynamics are changing over time. And of course, this is ideal to put some computational modeling. And so Patricia Garcia Cañadilla is like one of the people currently working as data scientist and modeler in the Children's Hospital here in Barcelona. She developed this computational model of the fetal circulation, where of course we used a lumped kind of equivalent kind of electrical circuit in order to make it computational efficient. And also I'm a great believer in these, especially when it goes about flows. Of course, you don't need to go in more detail. And what we could show there is that we can really kind of reproduce these patterns, and especially the continuum of these patterns when we do these simulations. And what is interesting is that these, of course, are linked to the diagnosis. So we can use that for diagnosis. But we can actually go already one step further. So once you have this, you can also go further, and you can actually try to integrate different techniques in order to understand. And here is something that is kind of very recent that we're doing. We're doing a study to try to see whether we can improve the well-being and the evolution of these babies by giving the mother oxygen. Because what I said before, the placenta is too small, there's not enough oxygen delivery. So if we give the mother 100% oxygen, so with what we call like hyperoxygenation therapy, does the fetus actually improve with it? And so what we did is we measured some fetuses, and we did our machine learning there on how the Dopplers are changing. And what we could see that indeed the fetuses that are abnormal, that have abnormal flows and are at risk, what we see is that actually their flows improve. And what you can see, again, I'm not going into the pathophysiology, but what you can see is that actually reflected waves from the lungs are being reduced. And so the forward flow in the lungs is actually working. And we did this by doing our dimensionality reduction and then trying to measure during the therapy, so under hyperoxygenation, how does a certain fetus move towards normality? And we can really kind of quantify these trajectories. And we saw indeed that the fetuses with the growth restriction, they do respond, while the others have actually no response whatsoever. If you have enough oxygen, you're not going to go and react to oxygen. At the same time, Patricia did the computational model. So where we really looked at the changes in the flows and then try to kind of quantify what are the resistances and the changes in resistance and of the pulmonary circulation and of the systemic circulation. And you really could see indeed that based on the data, so we use real input data in order to calibrate or kind of personalize the model. And what we could show is that under hyperoxygenation therapy, indeed, the pulmonary resistance of the abnormal fetuses is changing, is decreasing, while of the normal fetuses, this is not. So here you see already the complementarity. So while with the computational model, we can do measurements that we cannot do in clinical practice, but it has limitations. For example, because it doesn't look at wave reflection phenomena and things like that, we can use the machine learning to find something similar, but really go more in detail into the etiology, because that is, of course, based on the real data, but we need to know how to interpret it with the right kind of tools. And so here again is a very nice example of a real world setting. It's like, how do we interpret how a fetus is growing? And you see that when we look at our flow chart, again, in a real world, all of these are dependent on When is a mother coming? What are the resources that we have available? What is the local practice? How do we deal with this? Can we afford this? What is the decision that a clinician is making? So we have to keep that into account. And it even becomes more interesting / complex when we go to a lower income setting. And we're currently doing a project which is kind of sponsored by the Bill and Melinda Gates Foundation, and which we're doing with the Aga Khan University in Karachi in Pakistan. And what you see there is that, of course, because of the limited resources and the related limited expertise, we see that almost everything changes. And so what you see is that because of all these kind of things, when we really look at fetal well-being, we see that in Pakistan, what you see is that the child death and neonatal death is much, much higher than somewhere else, and is about roughly around 5%. So really 5% of the babies is dying before they become 2 years old. And when you look at the reasons why, is that, of course, there are some infections, but you see that there's actually a lot of problems which are related to birth. So it could be complications during birth, it could be congenital abnormalities, or it could be prematurity. And these are things that we might be able to detect if we find ways in order to integrate very easy ways of acquiring data with kind of helpful ways in order to make decisions based on, for example, machine learning. And so we started in this project a machine learning lab, and here's a picture of our machine learning lab in Karachi, in one of the kind of lower income fisher villages, which are next to the city. And so we have a group of people that we work with. And so what we do there is we do kind of Doppler acquisitions of the women. And what we do is we try with very easy to acquire a few kind of Doppler measurements. What we try to do is we try to do risk prediction. And our first kind of information tells us that this might be useful indeed. And also we can find ways why this is. And we see some things which are clearly related to this, what we said, this growth restriction, placental abnormalities, where the prevalence in Barcelona, for example, the prevalence would be 5%. In Karachi, it would be 15% because of malnutrition, because of iron deficiency, because of other habits and things like that. So these are things that we can maybe detect, and we then can make kind of scoring systems for this. And our predictions, because it's a really hard problem, especially slightly earlier in pregnancy, what we see is that we can actually work with a high sensitivity, but not a great specificity, especially for death. But keep in mind also that this is only less than 5% of abnormalities. So it's really a hard, unbalanced problem. Looking at these fetal abnormalities or these placental abnormalities is a little bit better. And this is actually important because that gives you higher risk. And this tells you that you better go to a tertiary center or more specialized care center, because maybe you need a cesarean section. And maybe also you need follow-up as kind of a fetus, or sorry, as a kind of neonate. Now, also very interestingly is that we compare different models. Again, due to lack of time, I'm not going to go in detail. But what we see is that our kind of system based on dimensionality reduction gives us a very high sensitivity, whereas traditional learning would give us a much more sensitivity, balanced sensitivity specificity. But when you think about screening, it's really the sensitivity that you need. And then you can decide for a cutoff, again, depending on the resources that are available, how you use this for escalating. You don't need to predict which are the fetuses that are going to die. What you need to predict is which are the ones at greater risk, because there we have to do a much better kind of antenatal follow-up. So here we can really change the paradigm of how this goes, because with helping with the acquisition and finding which is the data which is crucial for the interpretation, providing algorithms and preferably with an easy implementation in order to look at this data and explain to a non-trained person why this is useful, can really help in this case. So to conclude, it's like patient stratification is really not just having a classifier. Right? So what we really need to do is we need to understand the data. We need to understand the etiology. And so we need to know which are the parameters. How are these parameters changing? How are these changing within population? How are these changing over time? How are these changing with therapies? And can we use this in order to make decisions based on this? Physiological modeling can help us interpreting this, because we can explore the space and we can extract parameters which we otherwise cannot directly measure. And based on this, we can try to determine an etiology, or what I would call a phenotype, of which we can then look at the impact of therapies. And again, In these, we can either model therapies or measure them from no knowledge, and or put in the cost, because this is really important, because what we really need to do in our decision support systems, even in our modeling, we have to put cost of healthcare, because it's not affordable, especially when you go to lower income countries, but even in the higher income countries, unless we put this kind of cost measurement somehow in our decisions, they're never going to be used on the longer term. So based on this, we can choose our best cost-efficient therapy for this particular patient. And then again, of course, we need to titrate or optimize this therapy, where again, looking at temporal evolution, whether our patient would return to normality, for example, or not, or we can simulate a predicted behavior, for example. This is the way how we can do it. And all this has to be based on data, knowing the quality of the data, and trying to interpret the data as a whole without assuming the, in brackets, dimensionality reduction that is being done already in clinical practice, because that is based on evidence which might not be complete, keeping in mind that the data, of course, has a certain reliability and uncertainty. So I think really this type of approach will offer us in the future really true personalized and precision medicine, where we can always keeping in mind the way that clinicians are working for each of these blocks of kind of reasoning, of data extraction, of analysis. We can provide, I think, ways to help, and we can also choose the right algorithms in order to do it, where we always kind of look at the balance between interpretability, efficiency, and cost, for example, in order to do this. Thank you very much.
Okay, thank you for this great talk. So let's start with questions. I see that Jerome has raised his hand. So Jerome.
Thank you, Gemma. Thank you, Bart, for this very great talk. I have actually several questions. If you're short in time, Gemma, please feel free to cut us. So my first question is related to the first part that you have presented in cardiac phenogrouping. Mm-hmm. I'm wondering, so when you're using the data to feed your dimensionality reduction and then your clustering of patients, are you using only raw data, or are you post-processing this raw data, so according to different models, curve fittings, etc.? And then if yes, do you think that it would be necessary to consider some possible error propagation due to this post-processing of the raw data?
Yeah. At the moment, we indeed use some post-processing. As I said before, what we currently do is, although, for example, the Dopplers and then the strains are extracted from images, we use traces. So we do segmentation of the Dopplers and we do calculations of the strains. For the strains, we use commercially available products that they use in daily clinical practice. The only thing is that we use it over the whole cardiac cycle. For the Dopplers, we made our own system. And the other thing is also for the Dopplers, what you also need to do is not only do you need to do the envelope, but you need to detect some kind of control points, let's say it that way. So the onset, so valve closures and things like that, so and maxima and things like that. So in the end, we do indeed some kind of curve fitting partially based on these control points. Now, does that introduce an error? Probably. Do we propagate it now? No. But the nice thing with the dimensionality reduction is, of course, that this variability that we show, that also it shows the variability on the data versus the variability on the physiology, they are both showing in some ways. Huh? So the question is, of course, they can overlap. The question is, can we split this? Now, the problem is that the Doppler itself is, I think, even less reliable than the segmentation, for example, because also with Dopplers, of course, it's like, what is exactly the envelope? How was the probe being used? Because you might have some angle problems and things like that. So while I think in some cases it's a great idea to do it, I think in reality, when you really work with clinical data, it's not that easy. What I'm more in favor of in some ways is trying to use the results of the dimensionality reduction and trying to interpret which is based on physiological variability and which might be based on some kind of error propagation. And that, I think, is something that we really need to do more. We are trying to do that a little bit, but not so much. So I think you have a real point that this needs to be taken into account. And this is what people often forget. What is the best way to do it? I'm not completely sure. But for example, also when you use then computational models in order to generate this data, this is actually a nice way you can do it. So you can put some errors in there and then see how that translates to the dimensionality reduction. So, and also for data augmentation, for example, computational models are really great because at some point we started with that. This is something we still have in the back of our mind. So I would rather see it as helping to interpret the data rather than putting it into the process itself at this moment. I mean, that's the choice that we made.
Yeah, okay, thanks. And then my second question, it's technical curiosity, then also about this first part. When you're using multiple kernel learning to reduce your dimensionality, what is the least amount of data according to your experience that you need? My own experience is that nonlinear dimensionality reduction can very suffer from the lack of data, from insufficient.
Yeah, well, this is not our experience. The thing is, we have been doing several studies with maybe only 50 patients or something like that, and you start to see already very interesting things. What we see is in the larger studies, so I think it really depends on the population that you're studying. So it really depends on the variability within the population in some ways. When we go to more homogeneous studies of some kind of clinical, or when we go, for example, to these more cohorts or things like that, our impression is that that starting from roughly around 500 patients, you mostly capture all the variability which is relevant. Keep in mind that we use complex data. So when you look at the number of features, we have at least 3,000-4,000 number of data points in some ways because we use these complex data. So of course that's also already different. Now, in some ways, the interesting thing is that you can also, and these are things that we are investigating, you can also try to calculate the representativeness in some ways of the space for a new patient. So if you see that a new patient is either projecting way out of the space or is projecting very close to the center of the space, you know that maybe your space is not capturing it. So in that sense, it's a little bit, that's why I say like outlier detection, I think is super important. And this gives you a natural way in some way to do outlier detection because you really see that some things are happening. And so in that sense, it's like, as I say, our experience is better with regard to the number of patients. And at this moment, even using really thousands of patients is computationally. So, because when you start to use the study that I said with our 10,000 patients, we learned on 7,500, and we had to go to the supercomputer, kind of calculating 1 week in order to calculate the space. So in that sense, it's not scalable enough for huge data, but there's other ways in order to do that. Right? So. But I think with limited data, but with physiological knowledge in order to interpret it, I think it works fine. That's our experience, at least.
Thanks. And then my last question regarding to the second part of your talk. So I'm wondering whether you're testing this risk classification or risk detection with a counterpart in developed countries where, I don't know, where maybe the echograph of our better quality, etc., just to test actually then the robustness of the pipeline with maybe better quality raw data.
Yes, well, we are doing that. Now, the better quality raw data, the thing is, in our study in Pakistan currently, because it was sponsored in some ways and because it's an initial study, we could use a very modern echo machine, actually the same machine that we use here. And the person was really trained well. So actually the data quality is at least as good as here. But we are indeed, there's some studies that we hear in the maternity hospital here in Barcelona that we're also running. The idea is to really compare the data and see whether it's similar. But our first kind of indications is that we have very similar findings in some ways. The only thing is, of course, the percentage of abnormal outcome is 10 times higher, at least in Pakistan compared to here. So, and now we're starting to study on larger ways and going more deeper into it. And then hopefully in 2 years, I can tell you what the differences would be and where it is. But we are looking indeed at different places.
Thank you very much, Bart.
Okay, and we have a question from Ahmad Al-Minawi. I don't know, Ahmad, if you want to voice your question.
Yes. Hello. First of all, I would like to thank you all. And my question is, after introducing the individual analysis, so basically after learning, would this also affect the decision making by adding new data to the database or not? So was like the data only collected beforehand and that's it, or was it also like progressed afterwards?
Yeah, up to now, we have been working on just learning in one phase and then using it afterwards. But there is also one of our PhD students is also working on what we call like incremental learning, or you can do it online learning, where indeed every patient that we make a decision would then be added to the learned space in order to be used later on. So there's different ways of it. So the idea is to do that in the future. And of course, the idea is then even to go to federated learning, where, because one of the big problems with all this kind of things is data transfer. Because when you work with clinical hospitals, it's extremely difficult to have data transfer agreements where you can use data. So the idea would be to find some ways to learn the space or update the space and use the space locally without data transfer, but try to share how the space is being used. So these are things that we try to work on, but it will take a couple of years in order to really have the answers for this. So,
do you think that might like increase the error later on, like by introducing new data to the original data set or to the original database? Might that like increase the error, especially because the as you said, like the dimension was low. So basically, not all of the differences were taken into consideration.
Yeah, I don't think it will increase the error in some ways, but everything depends on how you do it. But the more you use for learning, the better. Now, the problem is if you have a huge amount of very, very similar patients that you use, it might be that your learning becomes a little bit imbalanced. But there again, by trying to calculate the representativeness, so what you can try to do is calculate, do I already have a patient that looks very, very much like this patient? If yes, I'm not going to use this patient. You say like, okay, this is a new patient, very kind of dissimilar, then yes, I will use it. And so I think in the future, we will find ways to optimize this. So to do online learning, but at the same time also decide which are the ones that you're going to use for learning and how you're going to use it. So.
My second question was about the hyperoxygenation. Was it done in silico or was it actually done in hospitals on
actually no we did both. So we did it actually in pregnant women, and then we did the measurement. So we measured the changes in the Dopplers of the fetuses under hyperoxygenation. And then that data we used, at the one hand, we used it for the machine learning in order to see what the differences would be. And at the other hand, we used the outflow of the heart for our computational model. And then we predicted the changes or we try to personalize the model in order to predict the resistances of the lungs, which of course you cannot measure directly. So we did it indirectly. So it was based on actual data combined with both learning and modeling.
Interesting. Finally, just like how hard was it to like actually get like approval or permission to do like experiments on pregnant women or like on a fetus, basically?
Well, that depends. So you have to work together with obstetricians in their study. So we have a very close relationship with the maternity hospital here in Barcelona. I want to set up these studies together, but obviously, I mean, this has to go through the whole ethical committee. And so all these studies, they can take years in order to do it. Because, for example, this hyperoxygenation study also, like, I mean, say that 3 years ago, we started with planning it. And then after 3 years, you might have some kind of results, especially when it comes with modeling and machine learning. So, no, this takes a long time. So that's why you need to build a long-standing relationship with clinicians in order to be able to do this kind of things. And for example, also our study in Pakistan is also something that after years and years of collaboration, then, and also you need to get confidence, you need to show what you can do, you have to look at complementarity and things like that. So these are long-standing tasks that you have to find clinicians that like to work with you, that have a similar way of thinking about it. And then you slowly can build this up. So it took me 30 years as a professional in order to get to what I can present you this year, today. So
perfect. Thank you so much. Thank you.
Okay. Any more questions?
Maybe.
Anyway,
yeah.
Everybody can contact me if they have questions, because, and probably re-look at the video because it's a huge amount of information, I know.
But actually, I have another question. I think it would be interesting then for the attendees to have your opinion, your view, your experience about one of the hidden parts of the story, which is data infrastructure, data access. So we all know that that's quite a burden, but I think it would be really interesting to if you could share some words about this.
You point to the kind of the sore point of this whole. It's like, this is really the most difficult ever, because the problem is clinical data is not only sometimes not as good as people would say, but it's not stored or standardized in a way as a lot of people would say. So you can go and talk to a clinician and they say, oh, I mean, I have hundreds of patients of this. It's like, and then you say, okay, give me a copy of the data. And they say like, oh yeah, I don't know where it is or how it's stored or things like that. So there's very, very few places in the world. There are a couple, very few that have standardized databases for all of the data. Most do not have. What we do here, for example, is what you really need to do is, if you're an engineering researcher in this, you really have to go to the doctors, you have to ask them, where is it? And you really have to copy the data one by one. Sometimes you even have to go to some kind of clinical systems and type it into Excel or whatever. You really have to go kind of hands-on and try to do it. Or you can be lucky. This is what we often do. That again, that's where you have this relationship, is that very often you hook to a medical PhD student, for example. And then this way, because you're working on the same project, you both have the same kind of interest in the data, then you can get it. We're trying now to set up ways to have more like data lakes or kind of standardized systems. But the problem is that, especially with the changes in the law recently, it becomes actually much more difficult. And now even data transfer agreements, our latest data transfer agreement for collaboration, where we would transfer totally anonymized data of our fetuses and some kind of children to a collaborator that we know for years and years and years. It took 1 year of the lawyers talking together before we can transfer anonymized data. So it's really a pain in the ass, in the sense that the data itself, the availability of the data and where it's stored, that is a problem. But secondly, in order to do it, like if you need to transfer data, that's very difficult. So that's why either being in the hospital or having an agreement of like a collaboration with the hospital makes it much, much easier to work on this. But there are still a lot of problems. It's like, I don't know, there's a couple of, like some for learning, for example, a couple of echocardiography databases available. But again, these are not useful for really doing clinical studies in some ways. What you see now is, what is an advantage is that the clinical trials, for example, that are going through NIH, they are starting to give their data after 3 years. So the data should become open in some ways, or you should be able to have access. It's like, that is interesting. But keep in mind, as I said before, that is this trial data. So you can learn on trial data as much as you want. To transfer it then to clinical practice is something totally different. So there again, you have to be like, the data that is easily available is not representative. The data that is representative is not easily available. So that really is a problem.
Yeah, thanks. So I know, for example, that at the European level, the European Commission is starting to think about how actually to regulate data access, to make larger access, to better data quality. That won't be easy, because of course they will have to fight with all local regulations. Yes. That's on the way. I don't know how long it will take, but yeah.
But it's not only the regulations. Very often it's that you have to fight with the local informatics people. So in the hospital, the informatics are mostly regulated by a local department. There's only few that are starting to outsource it. So the outsourcing, I think, which might be making it more standardized. But the thing is, like, these people, they might be competent and they might be nice, but their priority is not giving you the data. So that means that they don't have easy ways or to do it, or they're not willing to put an experimental system in there, which then kind of might compromise the integrity of the whole network and things like that. So you're fighting against a whole bunch of things. So to me, the only way really forward is that you're closely collaborating with a clinician, ideally with some kind of collaboration agreement that you partially work in that hospital for one day, or you have a PhD student that works in brackets in that hospital, or together with a medical student there. That's the easiest way to get the data or get access to the data, because then you have common interests in some ways. And then it can be regulated that this falls within the laws and things like that. But otherwise, it really is difficult, I can tell you.
Okay, thanks.
Okay, so if not more questions, thank you, Bart, for sharing with us your time and your experience. And I guess now we have 5 minutes break,
Yes.